Good evening, everyone. The suspense. It's so wonderful to see so many of you here with us this evening. It's a very full room, which is brilliant news. Some familiar faces and some new ones too, which is always lovely. Thank you so much for joining us at the Lanserhof at the Arts Club for our Restore and Rebuild event. For those that I have not yet met, my name is Victoria Smart and I am from the Beauty Triangle. And I am really honoured to be joined this evening by three fantastic practitioners. Paul, you feel very far away. I'm going to try and shuffle in a little bit. Who are going to be discussing new routes to restore and rebuild our bodies, because I'm sure we can all agree that there become some times in life when we feel like we may need a helping hand, whether that is to restore the most intimate parts of ourselves and to rebalance our hormones, to restore the parts that make us feel most feminine for the women in the room, whether that's your breasts or other parts of your body, or perhaps to address some pain or discomfort that you're feeling and to address your form and your function. Now, those are just a few of the things that we're going to be discussing today. But before we do, just some housekeeping. You should all have a programme on your seat place there. In there, you'll find further information about each of our speakers, as well as a referral card. So should you wish to be connected with anyone that you hear speak this evening, please just pop down your details and we will connect you after the conversation. There's also a goodie bag for everybody this evening with a fantastic supplement from Ancient and Brave, so please do not leave without that. And just before we begin, a few words about the Beauty Triangle for those that aren't familiar. We launched 6 years ago now with the aim to educate and empower audiences, such as yourselves, on all areas of well-being, but importantly from a holistic point of view, which is why you will always find 3 panellists, each of whom are an expert in their practice. But we also launched in order to connect you, our audiences, with these authorities, which brings me very neatly to introduce today's panellists. We have consultant gynaecologist, Miss Smita Sinha. We have consultant plastic surgeon and co-founder of Purity Bridge in Tunbridge Wells, Mr. Marc Pacifico. And we have, down the end there, osteopath and physiotherapist here at Lanserhof at the Arts Club, Paul Marsat. Now that's enough from me. I'm going to hand over to our speakers to say a very quick hello and introduce themselves, and then we will get started with the main conversation. Smita.
Thank you ever so much, and it's wonderful to be here this evening amongst you all. So as Victoria kindly said, my name is Smita, I'm a consultant gynaecologist. I've got over 17 years experience in women's health. I currently specialise in menopause and vulval health, as well as intimate wellness, which we'll hopefully talk a little bit more about this evening. I'm based in Somerset and also a beautiful clinic in London, which is Lisa Franklin's in South Kensington as well, where we offer a wonderful array of really holistic women's wellness treatments and treatment plans.
Mark?
Just try and put this on. Bear with me.
Light on?
Lights on. Hi, I'm Marc Pacifico. So thank you again, Victoria. I'm a consultant plastic surgeon, based mainly in Tunbridge Wells, but also on Harley Street. And my principal interests are surgery to the face and the breast. I was the president of BARTS, the British Association of Aesthetic Plastic Surgeons, until last year, and I'm very involved in speaking and training colleagues. I do a lot of international lecturing and thoroughly enjoy what I do.
Thank you, Mark. And Paul?
Hello, everybody. Nice to see everybody. My name is Paul Marsat, so I'm a physiotherapist and osteopath. I have a general practice and I treat newborns up to elder people, and I work with neurological cases, sports people, everything I do purposely keep my practice quite general. I work here at the Lanserhof. I also work at my own practice in South Kensington, and I work for a professional football club called Brentford. I do osteopath there, so keep myself very busy. Very excited to be here tonight, and I was very impressed with all the practice questions we did with Victoria, so it's going to be a very, very detailed evening.
Don't let them slip, Paul. So Smita, I'll start with you. Gynecology is something that we're definitely speaking more about now. It's always been taboo, and I think that still exists. But I'd love for you to start by explaining who are the people that you see in your clinic and what are their main concerns?
Yeah, absolutely. I think women's health is one of those things that we really have to be able to start addressing fully for all age groups as well. We know that there is a big gender health gap, and I don't want to start the evening on a downer, but there's lots we can do about that. So a lot of the women that I will see in my practice are coming absolutely, for the sort of title of this evening, they want to be able to rebuild and restore their lives when it seems to be coming apart a little bit. So that can be through hormonal fluctuations, it may be to do with menstrual problems, as well as intimate health problems, so specifically around vulval health and the difficulties that that might bring about with the symptoms and changes that women can face. And all-encompassing around all of that is intimate wellness, which plays a profound part in lives for women and for quality of life. And it's really important as well that we are able to address these issues and acknowledge them, and also provide support and treatments and managements for them.
I'd love to start by speaking about intimate health. What are the concerns that people are presenting with most commonly in your clinic?
So for me, when we talk about intimate health, I'm sort of talking about the functional aspects of things. So this is also to do with education around what it is that we're discussing. So we're talking about the vulva, we're talking about vagina, we're talking about the bladder as well. And it's number one thing that I want to do in my clinics as well is help educate. And really be able to empower women to feel that it's okay to say these words, because I think we all know we sometimes will defer from using the correct anatomy, and it sort of starts from that and that connection. But there's a whole range of changes that can take place, and this can be symptoms to do with dryness, it can be to do with changes in sensation, so a sensation of burning, changes with intercourse and satisfaction through intercourse, which is a hugely important part of quality of life. And they can happen for different reasons and at different times, so there's not a specific time. It can be linked with hormonal changes, which could be taking place after sort of pregnancy, breastfeeding, any medications, any surgeries, any cancer treatments, and then of course through the menopause and beyond. So there's really any time that these changes can be affecting women, which is why it's really important to be able to address it and to be able to talk about it.
I think it's really interesting what you say there about advocating for ourselves and using that language, because ultimately if we turn up to see practitioners and we don't even know which parts we're speaking about, then it can be really difficult to even start to explain those symptoms. When people are presenting to you with, I don't know, dryness or uncomfortable intercourse, what is it that you are doing in clinic to help support them through those times?
I think it's acknowledging those symptoms as well, because we know that a huge amount of women won't feel comfortable to see their healthcare practitioners about this, to bring it up, or even to think of it as a concern or a condition that could be helped. And I just wanted to come back to what you mentioned as well, that it's also healthcare providers that are just as much at fault in terms of not using the correct anatomy as well, and terminology. So you can end up in a situation where you've sort of got the blind leading the blind, really. So someone's sort of talking about down there, or may even refer to the lady garden and anything other than actually using the words. However, as I say, in terms of getting the most efficiency out of your appointments, if you're able to identify those changes that have taken place, which begins with that awareness and also self-examination, which is really important. So we know for things like breast health, for example, it's really important to check your breast, but it's very similar with vulval health as well, so that you know what's healthy for you.
And to take it straight there, how do you recommend that we do examine ourselves for the woman in the room? Sorry.
Do you like a demonstration?
Not quite, but I think even understanding how to do that is uncomfortable. I've since been shown about how to do it with a mirror, etc., a menopause event, but actually before that I even was like, well, where do I start?
Yeah, absolutely. So I think, first of the month is a great time. It's a new reset. It's a time to just, as women, to be proactive with our health and check your breasts and then check vulva. So yes, definitely, you're going to need a mirror. There's no other way at the moment that we can visualise the area, but I often just suggest sort of if you're sat on the toilet even, then placing a mirror so that it's angled towards the vulva, and then you can have usually have a clear view and be able to identify the areas, see what the colour is, see what the shape is, because everyone is completely different. There is no sort of normal, and that's also another thing that I don't use in my clinics is the word normal when it comes to explaining or describing the anatomy, because everyone's different. So it's more about what's healthy for you. And if things start to change, it could be that it's feeling a bit uncomfortable, it's a bit irritable. it's looking a bit redder, it's getting a bit angrier, because there's that dryness there, it's reacting, and you might notice that that's there. But equally, it might become very pale, and that might signify underlying skin conditions, which, as mentioned, need to be evaluated and diagnosed for appropriate management.
And you mentioned before that some things are sometimes common, but that doesn't mean they're normal, does it? I think, like you were saying, people are like, oh, it's normal. It's not that it's normal, it's just common. You stated some statistics to me, which I found quite fascinating when it comes to intimate health. Would you mind sharing those?
Yeah, absolutely. I think it's, again, with a lot of women's health, is that we will perhaps normalise things, or that's what we are used to doing. So, you know, a common thing is we can all be sat around having a really good laugh, and some of us might just be like, oh, please don't make me laugh that much, I'm going to pee. And we'll just laugh about that. But actually, you know, there are things that can be done about that, sort of urinary leaking and changes that are happening with bladder control as well. But in terms of the intimate health and dryness, so we know at least 50% of women going through menopause will experience dryness. So 1 in 2, and that number is increased in certain groups as well. So breast cancer survivors, for example, we know, again, through their treatments and their journeys that they're going through, they probably are likely to experience it more, so perhaps 75 to 80% of that group will experience these symptoms. So it's a huge number, and you know, that's why we need to be able to be more comfortable at discussing it.
And once we've discovered that we may have something that we need to address, how do you address those in clinic? What treatments or techniques do you have available?
So it can be sort of simple take-home measures and at-home measures that you incorporate into your regime. So sometimes it's the don'ts, so it's knowing actually when your skin is sensitive and it's had changes to it, or there's an underlying skin condition there, things like lichen sclerosis, lichen planus, that the skin is not going to react very well to a number of products. So things including incorporating fragrances. There's any dyed products, so thinking about what's in the toilet paper, in your underwear, the detergents that you're using, and also anything that's in sort of products as well. So lubricants, for example, are quite a big culprit in terms of what they're actually made up of. So we're sort of educating around that. Washing practices and clothing as well can make a big difference. So if your skin's feeling sore and uncomfortable, then it's sort of trying to wear more cotton underwear or silk underwear even. And then it's your practices that you can incorporate. So non-cosmetic moisturizers known as emollients and ointment form of these are the number one thing that I give my patients. And often the number one thing that will make a difference. They may have already had their diagnosis and they've come to see me as a specialist in vulval health, and they're just sort of like, we've got all of this, it's not working. And it's about having that time to explain, actually going through a regime with them, giving them the reassurance and the support that they need in terms of how do we do that. So diagrams that they can go home with in terms of where do we need to apply this, how do we do this, and sort of tips like that. But that's the number one thing. And then non-hormonal, hormonal treatments such as estrogens, if it's related to hormonal changes, or it could be steroid, and again, ointments if it's down to underlying skin conditions.
And we'll touch on the hormonal options in a moment, but what could they do in your clinic? Is there any technologies or treatments that they can be having if they come and see you?
Yeah, absolutely. So we've also got the ability to discuss some of the more advanced regenerative options that are available, which can form an adjunct treatment and supportive treatments. And that can include things to do with energy-based treatments, so radiofrequency with microneedling, as well as addressing the pelvic floor health as well. So we've got electromagnetic stimulation that can really help to stimulate and support your pelvic floor exercises. And then it's also just looking at skin health, the skin quality, improving that collagen and the elastin in the skin as well, which also changes, and building up that resilience for sort of future as well.
Those devices sound quite scary, but they're not so scary as they sound, are they?
I totally appreciate it. It can sound quite scary, but no. So if it's needed, we use appropriate numbing cream, and that can be very comfortable for people. And at the other side of things, it might, if you can imagine it, feel like a bit like a hot stone massage for your vagina. So,
Sounds tempting.
yeah.
And I'd like to touch now on hormones as well, because you say that you see a lot of your patients going through the menopause, but also before that as well, we focus often on the menopause as being that cliff moment where our hormones all of a sudden change, but it's a gradual build-up, isn't it? And we should be looking at that at every age of our life. What are the main signs and symptoms that your patients present with when it comes to hormonal?
Yeah, absolutely. I think it is, awareness is a really, really important thing. So, unlike maybe other conditions in women's health, we are all going to go through menopause. So 100% of women will go through menopause. And I think it's, again, for those reasons that we are now seeing more and more of these discussions and conversations, which is fantastic. But as with many other things, I think just having that awareness and anticipation can just help us to stay in control of these changes as well when they do start to happen. Simple things like cycle tracking might be something which is good to start with, so you're aware of what's happening with your periods and if there are any changes with that in terms of being able to address those in good time. And then it's many other changes that start to happen before the traditional hot flushes that I typically see in my practice. So actually it might be more that sleep's really affected. The mood might be changing as well. So whether that's onset of anxieties or if it's issues to do with irritability or lots of other things, new onset of panic attacks, for example, can start to happen with hormonal changes. But also things that we can sort of stay in control of, just looking at sleep practices, our exercise, our nutrition as well. So really addressing some of those longer term impacts of hormonal changes on the menopause, such as your bone health. So improving, and your heart health as well, so improving sort of fibre, protein, your calcium intake, vitamin D intake. So lots of things that we can be proactive about. And just be keeping an eye on whether those symptoms are starting to happen.
It's interesting that you mentioned bone health there, because I feel like there's quite a lot of conversation around that at the moment, and enjoying weightlifting and trying to lift as much weight as possible being women. When it comes to hormonal replacement therapies, where do you sit on that and how do you advise your patients?
I think it's part of the toolkit, so there's absolutely a place for it, and it is always down to an informed decision, and also for the patient to be able to be informed about what options there are for them, and to be supported in terms of the pros and cons for all of them, and then to be able to make that decision for themselves with your guidance. So we know in the UK, for example, it's really only about 14% of women that are on HRT, so there's still a huge number of women that aren't using that and are using other options or treatments, and that's absolutely fine. It really is just down to what support that woman needs.
And if we're trying to understand what we need, because sometimes we might be feeling all of these things but have absolutely no idea whether our hormones are imbalanced, what role does testing play in your clinic?
So I think testing's interesting. Again, with the guidance, there's no real sort of place for testing over the age of 45 when it comes to estrogen levels. There are different stages, and again, depends exactly what we're looking for. But when it comes to, if we're talking about menopause management, most of the time it's actually listening to the woman and listening to the symptoms that they're presenting with. We don't really need a set of tests to confirm or refute that, even if we had the validation on those tests, which we don't really, and that's the difficulty about using them, because there's huge fluctuations in our hormones. So depending on when those tests are done, if you get a positive result, that might give you a guidance, but you probably will already have been experiencing those symptoms. If it doesn't, and the woman's still presenting with symptoms, I'm certainly not going to turn around and say it's not that. So, and you would be recommending for them to have repeat testing in 6 to 8 weeks, which is quite a long time to have to wait for an answer. But it can be helpful in terms of establishing effectiveness on treatment. So once treatment started, and just ensuring that are the levels right, is the medication being absorbed correctly? That's where we can get some information from the tests that we do. But what the options are available for us as far as testing goes is not fantastic at the moment. So that's why they're not being used really widely.
That's really interesting, thank you. And a really beautiful note to end on, this idea of relying on ourselves and understanding ourselves a bit more before we reach out for every tool that might be available. Thank you so much, Smita. We will have time for questions and answers at the end, so please hold fire until then. Marc.
Hi.
I'm really excited to speak to you, Marc, because I feel like plastic surgery can often have a taboo once more. And when I spoke with you about breasts, it really opened my eyes as to the reasons that people might be reaching out for these solutions and these surgeries. Could you start by explaining the patients in your clinic and who turns up to your door and what their main concerns are when it comes to rebuilding and restoring their bodies?
Absolutely. So fundamentally, I think what links most patients who come see me are body confidence issues, which may be a result of changes through pregnancy, childbirth, weight loss, aging, developmental concerns, how their breasts have developed with significant asymmetry or shape changes. And these are issues that affect patients on a day-to-day basis. And one of the goals I think is nice to sort of discuss with the patient is the goal of her having freedom not to have these as issues again in her life. And it's really rewarding when I speak to my patients, let's say 6 months or so after surgery, and we look back at the main concerns, what she hoped she had achieved with surgery, and it's very rewarding to see her sort of read with me what we'd recorded and think, oh my God, I've forgotten about that, and that's incredible.
It really goes to show the impact these surgeries are having emotionally as well as aesthetically, which is what we often focus on when we're speaking about plastic surgery. What are the surgical techniques that you use in your clinic? I know that you do a lot of revision surgery. If you could dive a little deeper.
How long have you got?
All evening.
So for me, my main areas, as I said before, are breast and face. And with breast, I tend to see more complex breast cases, whether they are patients who've had issues with breast implants or changes to their breasts over implants, or the other reasons I talked about with developmental issues or asymmetries, and of course very large breasted women with functional issues with them. And really I think the key is there's no cookie cutter procedure, there's no one size fits all procedure, and it's very much got to be tailored for the individual. And again, it's understanding more holistically why that patient's turned up to see me. What is it that's they're unable to do, or how is it affecting their life? And fundamentally, there's going to be a trade-off inevitably. They're going to have surgery, there's going to be a scar at least somewhere, and that scarring can be reasonably extensive depending on what we need to do. So it sounds very obvious, but it's got to be worth it. And I say to them, I don't want to make you different, I want you to be much better and feel much better about things. And therefore, an example, if you're, for example, feeling inhibited about showing your partner your breasts, or that's affecting intimacy, whatever I do and we do together has to solve that. We have to be as certain as possible that is going to result in a change in your life positively. So in terms of answering the question about what techniques, I like to think I've got a big armamentarium, and I can use whatever is appropriate for that patient in that situation.
I love what you say about working together, and you keep saying we as if you and your patient are a team, and I think that's really important, especially as a clinician, because it's a scary moment going for surgery and it can be extremely overwhelming. Do you often find yourself having those really difficult conversations with your patients and actually them changing their minds and deciding that it's not quite the right time?
The last patient I saw this afternoon, we talked each other, let's say, out of having surgery. Wow. Because we're not dealing with hard materials that we can bolt together, we're dealing with biological soft tissues, particularly on the face and the breast, and we've got to acknowledge what is possible, what's not possible, and coming back to, is that really worth it? So with my patient this afternoon, I said, well look, I can give you the scar that we would need to do what we think we might do, but I don't feel, in my experience, that that's going to give you a predictable result that will be worth it. And I persuaded her not to have surgery, which I think she was very happy with at the end of the day. And there's a saying very much in plastic surgery is what makes one's reputation on when one doesn't operate, and I think that's very true.
Where do you sit on these other solutions? If someone decides not to have surgery, there are so many other things that they can go and do, even when it comes to the breast. I know we speak more so to do with the face about aesthetic treatments, non-surgical treatments. How is that impacting your practice? Because there are some things out there that we can access so easily, and it is ultimately scary.
So if I briefly talk about breast and face, so there was a time when I was starting practice 15 years ago, there was an HA filler called macrolane, and this was viewed as this is the next big thing. It's going to replace breast implants. We're simply going to inject breasts with this filler and a lunchtime boob job, as it was marketed as. And very quietly, 2 years later, it was taken off the market because of the huge number of complications it caused. And sure as night is day, night follows day, it's making a resurgence, fillers in the breast. So it happens about every 10 years. And I think we see these things that go in cycles, and I'm getting inquiries about people seeing on social media, we can have filler in my breast now. And it's very, very scary because it causes huge amounts of problems, potential infections, and you can't take it out. It's not an implant you can just take out. It's spread throughout the breast tissue, throughout the muscle, under the breast. So please avoid. And in terms of the face, I think there's a role for the wide variety of non-surgical treatments. I think where I have a personal selfish interest is in the treatments that might affect the ease of me doing face and neck lifting surgery in the future. So anything that causes a lot of scar tissue, particularly indiscriminate scar tissue. So with surgery, we can see exactly where we are in different layers in the face. If you think about our faces being built a bit like onions, we can see which layer we're in. And therefore, even if I'm going into a face that someone's had a facelift before, the scar tissue is fairly predictable where it's going to be. Whereas with some treatments, biostimulating treatments, high energy based treatments, they cause indiscriminate scarring that fuses the different layers together. And that makes surgery much less predictable, more riskier. I need to see where the facial nerve is when I'm doing a facelift.
So when you're opening up the face to do the facelift, it looks different inside the structure.
For sure.
Wow.
Yeah.
That's a gruesome thought. And you spoke there about revision surgery, and that's something that you do often, and replacing implants. What role does that play in your practice, and how important is it for people to be aware of when they should be having those treatments done?
Yeah, I mean, in relation to implants have a lifespan, and I think it's really important. Anyone considering breast implants knows that they will inevitably be having surgery at some point in the future. Although my record is of 44-year-old implants, so she had them in the early 70s. They weren't in great shape, but she'd kept them in for 44 years, which is more than the 10 to 15 years we normally expect out of implants. And you've got to remember that someone who's had implants in for 15 years, her breasts are 15 years older than when the implants went in. And it's not uncommon to take out implants that have been in for 10, 20, 30 years and find there's nothing wrong with the implants, but of course the relationship of the breast to those implants has been totally different from what it was when they went in. So sometimes that revision surgery is about the breast more than the implants, or as much as the implants themselves.
And is that why it's so important to consider the time at which we're considering having these surgeries, whether that is, before or after menopause, for example, a huge change in the hormones during those times of life?
I think that's very true. It's like there's no good time to have a baby. Sometimes there's no perfect time to have surgery and these sorts of things. So it's looking at when at the least disruptive time. But one time I'm very cautious about, particularly revision breast surgery, is in a perimenopausal patient. So a 49-year-old, 50-year-old who's had implants in and her breasts are starting to change, I'd usually try and persuade them to wait another 2-3 years, because what may look good at the end of the surgery when she's 49 or 50 may not look right 2 or 3 years later. That's far too short a lifespan or longevity to have out of a surgical result.
And I know that you don't see particularly many younger people in your clinic, but it's for the same reason, right? I know that I could speak for some of my friends who decided at a younger age that they would like to have a breast job, but it's not the right time because of the changes that are taking place. When can we anticipate that those changes will stop and it is actually potentially the right time to be considering these operations?
I think for most young women, I think you've got to have a good reason to have any surgery under 20, I think. But I do perform that, particularly in the developmental anomalies. I saw a patient today. She was 18 when I did her breast reduction, but I took 1 kilogram off each breast. It's changed her life. I mean, totally changed her life. So again, it's not making a decision that covers everyone in a blanket way, but really tailoring what decisions you're making for the individual.
And I wanted to touch on breast reductions, but also tuberous breasts as well, because I think these are things that really affect the emotion of people, like you say, the form and the function of the way that they're living their lives. What role do those type of treatments play in your clinic?
Yeah, but so for those who haven't heard of conditions such as tuberous breast, they are, I hate the word abnormal, but they are very unusual shaped breasts that develop, often with a herniation of the breast tissue through a very widened and stretched areola. And these affect women, and particularly the young women, who are the main cohort who I see in profound ways. They won't go on summer holidays, they'll stop activities, they won't swim anymore, they isolate themselves from a lot of life because of these things. So it's incredibly rewarding, it's life-changing to do surgery that really impacts on them every day.
It's not just rebuilding and restoring the body, it's also their confidence and their emotional well-being as well.
Yeah, I mean, fundamentally, people are coming to my office because of confidence and self-esteem issues, whether that's to do with face, neck, breast. And as I said at the beginning, it's giving them the freedom to be relieved of those issues.
It's a really beautiful way of thinking about it. When it comes to preparing for these surgeries, is that an important part of the process as well, and also recovery?
Absolutely. I mean, we are very supportive as a team at Purity Ridge, my clinic, and the prehabilitation, as it is often coined these days, is as important as the rehabilitation afterwards, whether that's with nutritional support, thinking about post-operative lymphatic drainage massage. There are lots of things that will just help those 1% marginal gains that ultimately will give someone a more predictable and overall better outcome.
What role does lymphatic drainage play before and after surgery?
I think, I'm not so sure before, but certainly after surgery, it's a game changer, particularly with things, cases such as face and neck lifts, when it totally relieves the swelling, and people come out with a session with our therapist Claire and feeling totally different compared with the hour before when they went in. It really does improve not only the physical recovery, but what I really like about it is spending extra time with someone who's an expert in what she does, who can reassure and spend time talking to the patient about her recovery, and that is invaluable in itself.
What can we be doing after these surgeries? I remember you explained a case where we have to stick to the rules of wearing the bras, etc. What are the important parts when we're leaving the surgery?
Well, I guess maintenance is a bit of a generalised term for everything from post-facial surgery through to body contouring or breast. The evidence for wearing a bra is not hard and scientific, but it makes sense to me. The skin is not a good bra, and therefore the more support you can give, it follows, the better. And for faces, I think well-chosen, bespoke, non-surgical interventions will really, without doubt, ensure the longevity of any facial surgery.
Is there anyone that these solutions aren't particularly the right choice for generally, or would you suggest that people do explore these options before they start also looking at other non-surgical aesthetic options?
I think fundamentally you've got to think, why are you doing it, or why are you thinking about it? And if you can't answer that question, then I'd stop there, because these are life decisions, having surgery, and we can't undo surgery once we've done it. And therefore, the more I go on in practice, the longer my consultations take, and the more almost philosophical the conversation becomes. It's not just about the risks of bleeding or infection or bad scars, it's about, is this the right thing for you at the right time in your life, and why are we doing it, why are you doing it now? And I think what's really interesting is when I ask those questions, how many patients pause and say, oh, I don't think I've thought about it like that. I think you ought to.
Yeah, I remember you saying to me that the more that you do this, the longer the consultations get, because that is potentially the most important part of your practice when you're seeing these patients.
Yeah, absolutely.
And my final question, as a pioneer in plastic surgery, what are you excited about, or what should we also be cautious of?
AI.
Interesting.
I think it's really interesting, and I talked to Francesca about this yesterday. What's really been an observation recently is how many people are doing research, not just putting a term into Google, but using ChatGPT and other AI modalities. And then you've got to think and recognise how AI might be programmed to search for the data it produces. And there are I think it's the start of a brave new world we're in on that front.
Do you have any examples? I'm fascinated to know what people are searching.
Yeah, of course I put myself in a few times to see what comes up. I saw a guy last week on Harley Street, and we were talking about mid-face and lower eyelid surgery. And I said, oh, how is it you've come to see me? And he said, well, I put into ChatGPT. I've blown my own trumpet here. It's something like, who should I see for this sort of surgery? And he said, well, I got 3 names came up, and I thought I'd see all 3 of you. And that was about the extent of his due diligence. Maybe that's a male thing, being a bit lazy and not doing too much research, but I think it's being used more and more.
I'd like to ask on that point, how do you recommend going about finding the right surgeon? Because that's an extremely important part of the process, and like you're saying, people are turning to things like ChatGPT. What's the right way to be doing it?
Yeah, it's really difficult, isn't it? If you don't know someone who's had surgery and a good outcome, who can't give you a personal recommendation, you're obviously going to turn to some sort of search function. And I think there are some basic credentialing. They've got to be on the specialist register for plastic surgery if they're a UK plastic surgeon. Otherwise, they're not a plastic surgeon. I'm biased because I was president of BARPS, but I would suggest they should be a member of BARPS. I think you've got to also research some. Instagram's obviously the shop window for plastic surgeons these days, so making sure that what they are posting is aligned with what you feel is in your mind as an appropriate result. And I don't get patients, for example, who want big breast implants, which I'm very happy about, because my digital footprint does not show those because I don't do those, and the patients then self-select other surgeons for that. And I think having some credibility in being a surgeon who often teaches and lectures other surgeons about their techniques and their results is, I guess, some professional credentialing from their peers. So I think that's probably the final thing I'd say.
You're being very modest, Mark. Thank you so much. That was a fascinating overview of all things breast surgery and face as well. Thank you, Mark. And finally, Paul.
Hi, Victoria. Come in a bit so we can see each other.
Shift together. I'm fascinated by your practice because it's completely holistic. When I spoke to you, I wasn't quite aware of the wealth of different expertise that you consider when you see the person in front of you. As an osteopath and a physiotherapist, can you explain what your patients' main concerns are when they're coming to see you?
Yes, thank you, Victoria. I think the main thing people come to see me with, sadly, is because of pain. It's often a very easy entry to come to see someone like me, because it kind of, even if you thought about it before in the past, it kind of just accelerates the whole thing. And then once you're in pain, you think, like even today, for example, I had 2 people out of the blue text me saying, can I see you today? That's usually how we often break the ice. And then they understand all the other layers of what I may do, but that's probably the first reason.
And when someone comes to you for pain that may seem very external, do you often find that is deep-rooted in issues that are more internal and not just that point of pain, for example, in the knee? Is that quite a common thing in your practice?
In some cases, sometimes the pain where it's located is very obvious, and it could be just because of a trauma or an overuse or something like that. But then if we come into the subject of more chronic pain, that becomes very interesting. Like someone who tells you I've had a 10-year history of neck pain, it's probably something deep inside of them. And I remember I told you when we spoke, it is to a certain extent when we get to the chronic pain sort of patients, I don't really give that much importance to where the pain actually is, because if someone has had a 10-year history of pain somewhere, then let's try to look at you globally and holistically. And that's probably much more relevant than where the pain is. It's very, very tempting when someone says I have pain there to push there and work on that place, but that person is a mix of many, many different things.
We'll speak shortly about the techniques that you use in clinic and the hands-on techniques, for example, but I'd like to ask about women's health, something that we've spoken about on the panel this evening. What are the most common concerns when women come into your clinic?
I find it very difficult as a man sometimes to, as I told you earlier, relate to women's health, because I think, as men we will never understand first-handed what women's health issues are about. But I think from seeing them again and again, you kind of get a sense, and you can kind of see patterns. I think these days the most common one I see is probably menopause or perimenopausal related symptoms. And I think it's extremely difficult to grasp. You said some very interesting things, Sunita, and people often ask me as if I have the obvious answer, but I don't always. I think to a certain extent, I think you said about the hormonal markers, which are not that relevant. I think in the end of the day, there's someone in front of you who has symptoms, and those symptoms are not just because of a spike in certain hormone or another one. So if someone feels that they have a whole soma of body of sensations, and sometimes the manual treatments, the osteopathy, any kind of maybe acupuncture, whatever can help to calm the system and bring balance to the hormone. There's a concept called homeostasis, which is a concept of inner peace and health, and there can be different markers that get you out of homeostasis and bring stress to the system. So generally, regardless of what patients have, my goal is to bring them to a sense of calm, and I believe that the body has the ability to heal itself in the right circumstances, and I see myself as an adjunct to that, to help bring that homeostasis. I'm just a helper. Otherwise, I think endometriosis, polycystic ovaries, and fibroids are probably the other 3 things I see the most. Again, I think I had a lady get her fibroid taken out the other day, and she actually showed me a picture, and it's incredible the size of the fibroid. And when you think of endometriosis or fibroids or things like that, how big it can become and how much space, it's quite self-explanatory to what extent it can change your center of gravity or the way it pulls on certain ligaments or other organs. And so, although there's something growing inside of you, you can still sort of release it, push it around, help that tension to be relieved.
And do you take a more hands-on approach if someone comes in with those types of symptoms? What are the techniques that you're using? Is it a hands-on approach, or are you doing more of an overall assessment?
So when you say overall assessment?
So do you do more like manual, like when I think of osteopathy, I feel like someone's cracking my back and twisting my neck and doing all those things that feel amazing in the moment. Is that the approach that you take in your clinic?
So I think the cracks and stuff, they get very popular, but they take 1 minute, and then there's still another 49 minutes or half an hour or whatever to furnish in the treatment. So I think the osteopathy is whatever happens after that 1 minute. Sometimes you'll see osteopaths don't even crack at all. So I'm very hands-on personally, yes. I mean, you mentioned Smita about electromagnetic energy. So for example, I do use some machines, some machinery. We can maybe touch on that afterwards. But yes, my approach is very hands-on.
Which machines do you use?
So with regards to the electromagnetic energy, it's called TECAR. It's a machine which is electromagnetic, and basically you put a plate under the body where you want to work on, and there's a probe. And actually we've had it here now for 1 week, so yeah. But I've been using it for over 7-8 years now. And you have a probe, and you can decide how deep you want the energy to go, and how strong. You can either have it just go 3 centimeters deep, or have it touch the plate and come back. So it's very efficient to get sort of deep into the organs or deep into joints. I've had miracles really with this kind of approach. For example, very arthritic knees, where in my profession it's very difficult to access deep into tissues. I mean, I can use my own energy fields, but otherwise this machinery, for example, has been very efficient. So thinking about organs which are a bit victim of maybe hypoxia. So still talking about the homeostasis, the term hypoxia means generally lack of oxygen. And just to extrapolate a little bit, there's a nervous system in us called the autonomic nervous system, and there's 2 types. There's an exciting and a calming. And most of the time, when you're always on the exciting nervous system, which we tend to be driven a lot these days, the blood and the energy will be directed towards the organs such as the muscles, the brain, the lungs, and other organs such as maybe your uterus or your gut, or all these maybe secondary short-term wise organs. They will be neglected, and then there's less oxygen going there, less blood, and therefore these tissues, they tend to thicken, they become fibrous, and they become just they're not working as well. So those tissues, how do you treat them? Because yes, okay, you need to breathe, relax, and all these other things, change your approach to life. That's great. But then when you have adjuncts like the TechR, the machine I was telling you, you can actually get a very short-term direct effect on an organ where people will say, oh my goodness, you know, we did some treatment with the TechR. Doesn't have to be TechR, but even manual treatment on organs which are maybe a bit neglected, and they will say, my bowel movements were just incredible all week, or sometimes even women's health related wise there can be. I don't necessarily do that much internal work for ladies, but there's, for example, my wife, she does pelvic floor rehabilitation, and you know, you're directly working on organs, you know, inside the body, and you'll see very, very short-term blood rush and incredible effects.
It's interesting that you speak of the internal and the gut, and I know that we mentioned before IBS, when actually you started off by speaking about localized pain and someone explained that it might have pain in a certain place on the body. It just reminds me, and I'm sure everyone else, that our bodies are so connected and that it all plays a really important part. My one question is going to be, what other technologies do you have? Is there anything else exciting that's technology that you use in your clinic? And if not, what can we be doing from home that can help support this as well when they leave your clinic?
So there's one other machine I use probably even more than the TechR. It's called Shockwave. It sounds pretty brutal, but it's basically a gun. It looks kind of like a microphone, and you can direct how strong the waves are and the shocks, and you basically you can shock any part of the body, but you're sending very strong impacts, and you can put it very, very strong, and there's a bit of electricity as well. What this does is basically it bruises and traumatizes the tissue. But for example, a tendon that's been in a state of tendinopathy for years, or tendons intrinsically, they don't have much blood flow in the first place. So how can you bring life or attention to this tissue? There are obviously less invasive techniques, you know, manual techniques, but sometimes it can take a long time. So the shockwave is a very good way to get a very strong effect, and sometimes it will bruise. You'll see a very strong vascular reaction in that area, but it's very, very efficient, and then you can within 2-3 weeks get a really, really quick response to tissues that have been quite dormant.
Wow.
Yeah.
Do you see these devices being used instead of more intrusive, I don't know, injections or surgeries, etc., on these parts of the bodies?
Injection-wise, in my field, we don't have that many, which I would say are like magic. I mean, the cortisone injections tend to be less popular these days, especially with athletes, because you'll tend to find that it's just kind of putting an area a bit dormant. It's reducing inflammation, but it's not really fixing a problem. So as a one-off, it can be quite good. Probably in line with what I've been discussing, which is quite natural. There's this concept of PRP nowadays. I don't know if you guys use it in your practice, maybe in Facebook. Yeah, you don't, yeah. But it's basically retaking the good stuff in your blood and re-injecting it into a targeted area. It makes sense, it's good, and you can kind of mix it with shockwave as well. And I totally encourage that. It's not cheap, so people get frustrated if it doesn't work because there's no guarantee of anything. But yes, probably the PRP.
That's really interesting, aligned with what Smita said about relying on our own body's resources and more of a regenerative approach. Paul, what can we be doing from home to strengthen ourselves and rebuild?
So from home, I think it's probably the most powerful tool, because once you're out of the session, you know, you're kind of left alone. So you'll like, I had a treatment yesterday, for example, I had acupuncture. I came out, I was flying. I thought, my goodness, I'm unbeatable. I feel so strong. And then, you know, then I go again the next week, and then I go again the next week. I don't mind, but I can see that how some people don't mind getting treatment every week or every 2 weeks or whatever. But I think that intrinsically, even someone who gets a treatment, as I said at the beginning, I'm just a facilitator. They're treating themselves. So all the goodness is coming from the patient. I think I do maybe 49% of the work, they do 51. Okay. And that 51% is something you can probably take to 99 or even 100, because the magic is coming from within. You know, you have your own ability to heal yourself. So I think when you're getting treatments, for example, and someone's that goodness, that effect you're getting, or those points that you're working on, you can, through mindfulness or through own self-palpation or stretching or certain exercises, you can replicate that yourself to a certain extent. It's a practice. I mean, the whole yoga practice that's what it's supposed to be, is like an independent self-treatment. And you improve. So same way I improve in my techniques with people and the way I treat people, I think you improve as your own therapist. And sometimes I do weird things to myself. People find me doing treatments, and people often ask me, "Can you treat yourself?" Yes, I can to a certain extent. There is the effect of sometimes surprise when you're lying there and someone touches certain points. You can trick the nervous system. That's quite efficient. But when you're doing yourself, you kind of expect what's going to happen next. So sometimes it's not as efficient. But yes, totally, I think. But you need to get into that habit. I tell my patients, try, if you can, every morning, even if it's 5-10 minutes. First thing, lie down, do 2-3 stretches. Don't make it too complicated. And then from those 2-3 stretches, they will, by themselves maybe find new ones. And yeah, but even that 2-3 minutes a day you can do, it opens your day. You release all those tissues and all those tensions, and you'll feel better.
It's interesting what you say about consistency, because I think that's a large part, especially when it comes to physiotherapy. I remember leaving a physio and them telling me all of these exercises I knew that I would never do again once I'd stepped out of their room. Those stretches you mentioned, are there any in particular that we can be doing in general to help us for those 2-3 minutes every day?
You mean specific stretches?
Yeah, like we should be focusing on legs, back, neck.
I think probably the forward bend, especially for guys. There's not many guys in here, but just trying to bend forwards. Not necessarily trying to touch your toes, but trying to unwind your spine, because the spine is the mediator of everything, So the forward bend for guys, or even just the child pose, where you kind of get into a ball and you lengthen yourself. And probably the other one is, one of my favorite all time, is there's a big wheel like this and just lying in extension. Try to open your chest, because a lot of our emotions stay in our chest and our shoulders and then the front of the neck, trying to get the neck to open. So I think probably those two, if I had to just keep the two, yeah.
Look after your spine. I think that's what everyone in Pilates says, you're only as old as your spine is, so long as we keep that young. Thank you so much, Paul. Again, that was fascinating. And I love that you ended there on this idea of emotional release, which is something that we've touched on. Often when we think of rebuilding and restoring, we're thinking aesthetically, but actually it's the emotional part of each of the treatments that you're doing that is most powerful. Thank you so much to all of you. We do have some time for questions and answers if anyone is brave enough. I think there should be a microphone somewhere. Surely someone must. Wow. This never in the history of the beauty triangle. I know there was a lady that was thinking, never. You've covered it all so beautifully. Oh, there's one just here.
Thank you. Mark and I had a brief discussion, but just for everyone's benefit, because I know a lot of people would be interested. Mark, what procedures and energy-based devices would you as a plastic surgeon advise against if we wanted to have a facelift in the future?
So I think from an injectable point of view, it's going to be the biostimulators. I guess I shouldn't mention any brand names, but anything that I think is a little bit cheeky to call it biostimulation, because it's scar tissue creation, and the collagen that's produced by biostimulators is no different from the collagen produced from trauma from an injury. And certainly if you've had those in your cheeks or elsewhere within 2 years of a facelift, it really does affect the separation of the tissues, and it can be quite tricky. Even if someone's had it in 10 years previously, so my facelift from last week, I did talk to her afterwards saying, oh, did you have X, Y, or Z? Because I seem to find lots of debris in your face from it. And they said, oh yeah, I forgot about that. So it does last a long time. And then the other ones are the energy-based treatments, as I said, particularly, it's a funny thing, and this is anecdotal, but some people will find that certain treatments, energy-based treatments, work really well for them, and some will find they don't really do anything. And I think the ones who find they don't really do anything are easier surgically, the ones who find they've worked really well, they've worked really well for a reason, probably because they've caused a lot of scar tissue which contracts and tightens. And again, if I'm going into someone's, sorry, is this a bit graphic? Is that okay? If I'm going to someone's neck and they've had lots of energy-based treatments, the tissues don't separate in a normal way, and it is, we use phrases like chipping through concrete, and there's a lot more blood, and all these things, anything that adds time and complexity increases risk, and ultimately, as I said before, we're dealing with mobile soft tissues which have a degree of unpredictability anyway, so we want things to be as predictable and controlled as possible, and anything that hampers that is a little frustrating. So the things I would avoid in the 2 years, let's say, before having a facelift would be any injection that claims to be biostimulating, and any energy-based treatment that works particularly with heat below the level of the skin. And ultrasound, actually. High intensity focus ultrasound, HIFU, I'd avoid that.
I find that really fascinating because sometimes we can see aesthetic treatments as, like we've spoken about before, like this lunchtime quick fix, but also it's a decision to be making as well, isn't it, long term? We think of them as being everything's dissolvable, everything's reversible.
Yeah, and I think every treatment you have has potential implications. And I find filler in patients' faces that has been there for 10 years, and it was HA filler, surely that dissolves after 6 to 12 months, but it often doesn't. In fact, I'd say more commonly now, we understand how long it really lasts, and it either lasts because it becomes encapsulated so the body forms some scar tissue around it and therefore it will remain there forever, or it provokes a scar tissue reaction, so-called granulomas, and you find these bits which at the end of the day they can still produce good effects, even if it's by their unintended means, but they can just be problematic when we're trying to do something else.
But then could be the right thing if you weren't thinking of having a facelift. So
Absolutely.
Exactly,
Absolutely.
Two sides of the coin.
Yeah.
Thank you so much. I think our speakers will be here for a short while afterwards if you do have any other questions. But all that's left from me and the Beauty Triangle is a massive thank you for joining us today. It's so wonderful to see so many of you. We hope that you will join us again at our future events. We are now also hosting a large festival in January as well at 180 Health Club, which we would love you all to join us there. You can try and test and explore some of the things that we've been speaking about today, not facelifting, sorry Mark, but everything else will be available. So please do follow us, come reach out to one of the team, and a huge thank you to the Lanserhof at the Arts Club for hosting us so beautifully as always. And a final thank you to our Beauty Triangle. Thank you.